I have the daunting task to follow up my colleagues at Mayo, and I'm going to try to shift gears a little bit to talk about the pediatric experience with narcolepsy. So I just have some disclosures. I have served on a scientific advisory group with Jazz Pharmaceuticals. I've also done some consulting work for the Advanced Clinical Trials group, as well as I'm an associate editor at the Journal of Clinical Sleep Medicine. I thought to talk about a case, to start off with a case that I actually saw 2 weeks ago, so very timely. It does work? I was just checking to see if it's on. Oh, it's not on. Okay, thank you. So I saw a 17-year-old a couple of Thursdays ago. Was referred to me by the neurologist. Classic frequent episodes of daytime sleepiness. Resulted in him transitioning from going to school to now being homeschooled to accommodate his symptoms. Neurologist ordered a sleep study in MSLT, and then since I joined Rady Children's Hospital in San Diego, most of these patients were managed by the pediatric neurology group. None of them are board certified in sleep. That matters because certainly some of the pharmaceuticals that we prescribe require that attainment. So they now have started sending these kids to me, and I was lucky enough to see this child, and he had a sleep study that was consistent with narcolepsy. He did not have cataplexy in his history. And so if you look at the time, like he was first seen by a neurologist in February 2023, and our first opening was in September. So that's actually pretty quick. Before I came, it used to be even longer because there wasn't really a lot of sleep consultations that we could provide. But it just kind of goes to show that there is probably a need for more folks in pediatric sleep because these patients are coming at ages when they're children. And so I thought I was going to kind of talk about that experience of what it's like to be a child, to have a condition of hypersomnolence, whether it's narcolepsy or IH. And when I was thinking about this presentation, when I saw this child, I just wanted to ask him, give me 5 words of what you're experiencing right now. And so that's what he did. So he described his symptoms to me, and these were the 5 words, which I thought were very, very elegant, the way he described what he was feeling. Clearly he's tired. He was confused. But he's not familiar with this condition. Obviously, his neurologist says, I suspect you have narcolepsy. But, there wasn't a lot of dialogue that had happened because they hadn't seen a sleep physician. So he, went on the web and researched some things. Uncontrollable condition. His symptoms just were relentless. He was desperate. And then the last word, I think is one of the most important take-home messages, is that he was desperate. And that's, to me, kind of makes me emotional because, we really try to, all of us, no matter what we do, we always are trying to help folks. And when you hear somebody's desperate, you try your best to help somebody. And it makes me kind of disheartened that somebody's feeling that emotion because you really want to be there to assist them as they go through this journey. So today, just going to talk a little bit about an overview of narcolepsy and IH. I apologize, there's going to be a little bit of redundancy from what you learned this morning. Talk a little bit about features specific to children. Talk just briefly about treatment. There's Dr. Thorpe is giving great sessions tomorrow on medications. I'm not going to go too much on the medications, but just kind of highlight what it means to be a child to have these medications. And then more importantly, I'm going to talk about specific complications. So a bit of housekeeping. If you need to get up and walk around, please do. If you need to leave and get some fresh air, please do. If you need to go to the nap room, please do. If you just are bored and want to leave, please do that. I mean, I've gone through a lot of high school dances during my formative years, and I'm pretty numb to rejection at this point. So please feel free. So as you heard this morning, 0.05% prevalence, 1 in 2,000, similar to multiple sclerosis. But one thing you're going to probably hate about this talk is that we really don't have a firm grasp of these numbers in kids. And that's unsettling. We know that most people with narcolepsy and IH are probably undiagnosed. But if you ask me, what's the prevalence in kids, I just, again, plead the fifth. I don't know. Because the symptoms are probably there and just nobody's actually seen this child. So it's sort of a little bit of a crapshoot, I hate to say, to try to say what the prevalence of these conditions are in kids. And we've seen some graphics today talking about when the symptoms start, and I'm going to talk a little bit about that, just to kind of show you how I firmly believe a lot of these conditions should be considered or reclassified as pediatric diseases. So here's your bimodal age of distribution of symptoms, and so what you see here, clearly there's a peak by 20, but symptoms are starting before then, and so those are kids. Right? We classify kids as under 18, although that's actually changing, and I was actually having some great conversations last night about this, that we're probably thinking that kids are actually up to 25 because they're sticking on their parents' insurance plan with the ACA, and because of that, these kids, when they go off to college, and it has nothing to do with me, it's just how great our nursing team is, they just want to still be followed at Rady Children's Hospital. So we are accepting these kids who are 21, 22, they're off to college. And I'm actually very curious to see if this is a practice that is happening amongst my colleagues in pediatrics, because I find it's kind of daunting to, somebody's off. Like in Canada, I did college in my hometown. That's because there's not many options around where I was, but I don't know if that was the same for you in Ottawa, Paul, but in the States, the first decision is leave home and go somewhere else. And it makes it kind of challenging to deliver, people want these medications in a different state, and they want to be followed at where they've been following. So it's pretty clear that a lot of the patients have these symptoms before the age of 20. And so they should be starting to see their pediatrician. Whether they do is a little bit of a different question. Symptom prevalence. So as you know, number one is excessive daytime sleepiness. And as you guys all heard so eloquently this morning about cataplexy really being at least for narcolepsy, helping to differentiate narcolepsy type 1 and type 2. Now, it's interesting, cataplexy in children, and I'm going to talk about this, is challenging to identify. And it's also doesn't always arrive first thing. There's usually a lag for kids. They may develop cataplexy, but it's not apparent. And so what happens, as you heard, that if you don't have cataplexy, then you're going to get reclassified as narcolepsy type 2. And then if you have a crappy MSLT, you might actually get classified as IH. And guess what? In pediatrics, and it's probably our sleep lab, I hate to say, but we have crappy MSLTs. And so I don't know how many, I guess today we're supposed to be doing 10 MSLTs. I mean, that's what I heard from this morning, but it's really hard in kids to even classify when they have. And honestly, when you find that they have cataplexy, it makes it much more straightforward. But when there's not cataplexy, it's either type 1, type 2, or IH. And so that's the bit of a challenge there. So the one thing to think about in kids is that the presentation is not classical. And that's because kids, particularly young kids, we're not going to tell you that they're sleepy. And this is for all sleep disorders. Sleep apnea, periodic limb movements, insomnia. The actual cognitive perception of, I feel like I could sleep, that I'm not awake and that I have no alertness, I don't expect a 6-year-old to actually verbalize that. And so really, it's sort of this idea that it's not daytime sleepiness, but maybe more daytime symptoms. And so one of the classical things for sleep disorders, including narcolepsy and IH, is that they sometimes get classified as having attention deficit disorder or attention deficit hyperactivity disorder. Sleepiness can also be hidden in other behaviors. And so these kids might not, might actually express their symptoms as just being very irritable, very cranky, very aggressive. They might actually start showing signs of withdrawal. Depression might start to manifest, shyness. So you clearly have to be very open-minded when you approach a child because the symptom presentation is not uniform. Now, when you start to ask them about their sleep patterns, that probably makes it a little bit more clear. Certainly if they're sleeping more at night, if they're requiring, more periods of nighttime sleep, that might give you a sense of IH. If it's harder for them to wake up, that might also give you a sense. But you guys heard today about teenagers being night owls. So there's this, the late sleep phase syndrome, which is being a night owl. Those are the kids that go to bed late and have a real hard time waking up in the morning. And so they often might have just the same type of symptom. Now, thankfully, this is a plug for California. California became the first state to change their school times for high school students to be 8:30, which is incredible. Like, as a Canadian, they used to do. I started school at 8:30, and when I first came to the States to do my sleep training in Kentucky, I was seeing high school kids starting school at 7, and all of them were sleepy. They were all struggling, and I was like, this is ludicrous. But it was just partly because of travel, the way schools are. So California, thanks to some of the advocacy work by Dr. Pelayo and the folks up in Northern California, has actually made it a rule that we start school at 8:30. And so that's good. Guess what? It probably also helps our population with children with disorders of hypersomnolence, right? So that they have a little bit more time to get some sleep. Now, then the other thing in terms of the atypical presentation is daytime napping. As you all know, this is required, for at least for narcolepsy. Napping during the day is a part of pediatrics, right? When you think about young kids before school, they nap during the day. And the reappearance of napping during the day might be a sign that there's a disorder of central hypersomnolence. Now, what actually we were just having over lunch, I was just kind of talking about like how it's funny in the US and in Canada, you're not allowed to nap during the day. But if you go anywhere else in the world, yeah, nap during the day. That's part of your circadian dip. And I when I looked at the agenda for this session, I was like, they put me right after lunch where everybody's going to have a circadian dip anyway. But anyway, so if you see daytime napping emerge in a child that stopped napping, that's usually a red flag. Now, I think this is a repeated slide. All right, so this is the slide that I hate the most. Like, I just can't stand this slide. That there is a 10-year lag between when the symptoms develop and when a diagnosis is made. So many of you in this room know 10 years is a long time. Think about what's happened to you in the last 10 years. Well, let me rephrase this. 10 years is half of childhood. Half of your childhood is 10 years. So that to me means that we're not, this is really a combination of many things why there's a lag in diagnosis. I'm not going to talk too much about it, but one thing I know for sure is an element of that is it's hard to find somebody to make that diagnosis. And it's also hard to find a clinician to recognize what these symptoms are. All right, now, the child that I presented saw a neurologist. Neurologist was quite in tune, but often these children go see their pediatrician and they think it's ADHD. Guess what? They get put on stimulants for ADHD, which is partly a treatment. But the reality is they might have had narcolepsy this whole time. And then things get worse with their narcolepsy, and we could have been even more proactive with that child, with support groups like Narcolepsy Network, with other medications, with other behavioral approaches. So I hate this slide, but I have to present it because this is the kind of real world. Now, I want to just shift gears. I want to make sure that we spend most of the time today doing my best to try to answer your question. But I thought what we can do is talk a little bit about the associated features. And one of the things that is very common for kids is that they get sort of misclassified for a lot of other diseases. So I talked about ADHD, but depression, certainly like narcolepsy is associated with depression, but sometimes that's the only diagnosis they have is depression, when yet they might have narcolepsy or IH. Then there's actual social personality impacts, like these kids might feel inferior, they're sorrow, they have emotional lability. I mentioned they have issues with being irritable or aggressive, and school is a time to form your personality, But if you have symptoms of hypersomnolence and these personality changes occur, it really makes it hard to keep friends. You might get teased, you might get bullied. So again, half of their childhood, they might be experiencing some of this. So, really, one of my hopes is to try to at least engage, at least locally, that we can start to recognize some of these symptoms. We talked about attention, we talked about hyperactivity, but the net effect is these kids struggle with concentrating, and then that can not only result in poor school performance, but if they look sleepy in class, there's a lot of teenagers that sometimes get accused of saying, they're probably using marijuana. So that happens. And then lastly, there's this notion that hallucinations develop, and often a lot of these kids, if they see a psychiatrist, will be told they have schizophrenia. And so what we need to do as sleep physicians is we really need to work closely with our colleagues in psychiatry, neurology, general pediatrics, to try to educate them about some of these associated features. Another, this is a condition that is definitely observed in adults, but we have seen this as a surge in pediatrics, which is obesity. It's underreported for narcolepsy patients and IH patients, but the estimates it's about 25 to 50%, at least patients with narcolepsy have obesity. And the mechanism is unclear. It may actually be related to hypercretin. Somebody brought up today about GLP-1, which I thought was kind of interesting because it's looking at this notion of appetite regulation and hypothalamic function, and that certainly there probably is a role. It might be also related to being sedentary, and it might just be related to just the way that way you metabolize. And one thing that we're learning about obesity is it's not necessarily how much you take in, it's how you metabolize what you take in. So that matters. And guess what? Obesity is a big component of a lot of the personality aspects that can develop for these kids. They get bullied, they get teased. And then we are now starting to see a lot of the complications of obesity emerge in childhood. So type 2 diabetes, fatty liver, hypertension. These are all thought of as to being like adult diseases, but we are seeing this in the sleep clinic. I see fatty liver, I see diabetes, I see hypertension. In fact, one of the things that we try to do as best we can, sometimes these patients never get work, and they just see me for if it's snoring or for some type of a sleep problem, and they have obesity. I will actually try to work them up for this. And we've identified kids with fatty liver. We've identified kids with glucose intolerance. And I just want to get the train going, because one thing that I'm very, very concerned about, at least in the United States, is that the life expectancy is actually shrinking, which means that people are dying at an earlier age. And the number one cause of mortality remains cardiovascular disease. And so I'm very interested to see how we can change that as pediatricians. And at least in narcolepsy, there are these concerns. And it may be related independent to obesity. It might be just related to obesity. But there's been studies that have been recently published from adults looking at insurance claims that have supported elevations in risks of hypertension, stroke, diabetes. And I'm actually, my hypothesis is that this is actually starting as early as kids, particularly teens. And so we really need to do a good job trying to address that. Precocious puberty. So this is something that's very specific to pediatrics. The term precocious puberty means having puberty before the age of 8 in girls and before the age of 9 in boys. This is a complication specific to narcolepsy. Okay, it doesn't always happen. It is thought to be related to the hypothalamus, the area of the brain that regulates wake and sleep. Also happens to be the area of the brain that regulates hormones. It also may be associated with obesity. And just like obesity and having hypersomnia, it can also be a trigger for more teasing in school. So it also fosters some of the personality changes that might manifest for children with these conditions. All right, I want to talk a little bit about cataplexy because this is actually quite interesting in the pediatric world. because it's atypical, just like everything else about narcolepsy in kids. Sometimes it's thought to be a complex movement disorder, which whenever you hear those terms, the first thing that people think about is epilepsy. And this is the thing, is that it doesn't always present, as we heard before, with daytime sleepiness. It usually presents later, but in that sense that, if somebody does present with cataplexy early on, the knee-jerk reflex is to think it's some type of a movement disorder. And one of the things that we see in kids is they have sort of two types of cataplexy. They have negative cataplexy, which is the classic, you lose your muscle tone, you have head drops, you might have your mouth opening, but it's the positive cataplexy that we actually see in kids, which makes people think more that is this epilepsy, which is your eyebrows are raising, your tongue is pushing forward. It looks like they're actually gaining muscle tone as opposed to losing muscle tone. The grimacing of the face, and then just full, like what we call dystonic movements, where they're just look like they're adopting abnormal muscle tone. This is what we could say stereotypical, but these are features of cataplexy, but what we would consider as being positive cataplexy. And these are really hard to tease apart for kids because it's more often that when we see this, we think of an underlying movement disorder or epilepsy as opposed to thinking about cataplexy. So here's the slide that sort of is an addition to Dr. Cron's talk before, looking at the lag of cataplexy. This actually looks at both sleepiness and the other conditions of narcolepsy. And I just want to focus on first cataplexy. So you see sleepiness in kids starts earlier, and the cataplexy, it starts to actually be a little bit higher afterwards, like around the age of 20, sometimes even more common than sleepiness. And that's because maybe cataplexy hasn't developed at this time, or maybe kids are not able to report their cataplexy, or a combination of the two. I mean, when we see a 6-year-old or a 7-year-old try to verbalize some of these symptoms, it's really daunting. So we're really at the mercy of parents, teachers to try to visualize these things, but sometimes it's so subtle that you just don't know. And that goes in keeping with some of the other things like hypnagogic hallucinations and sleep paralysis. These also lag a little bit. It also might lag because it's just these young kids just don't know how to really report these symptoms. So we do struggle to identify some of the other aspects of narcolepsy, but sleepiness tends to be something that we can rely on, but more so for adolescents where they're actually reporting their sleepiness. So before I talk about IH, I'm just going to talk about narcolepsy by the age group, because this also kind of gives you a sense of the complexities of how narcolepsy can be. It's pretty, I hate to offend my adult colleagues, but I would think it's a little bit more straightforward to see an adult with narcolepsy than a child, and that's partly because of how heterogeneous narcolepsy can be in children. So it has been diagnosed in infants and toddlers. Will an infant or toddler say, I am sleepy? No. If I'm lucky if I can get my 16-month-old to say, call me Baba. But it has been diagnosed. And actually, I spoke with Emmanuel Mignot and asked him what the youngest he identified. He actually identified somebody from I think it was from the nursery. And I was like, how on earth did you identify narcolepsy in an infant? A, it's extremely rare, but B, it's basically thought to be, when an infant or a toddler is sleeping a lot through the day, we think of that as normal childhood. That's what children and infants do. But it tends to be more related to abnormal muscle tone. So it tends to be more of like the cataplexy type picture. So it is possible, particularly with exposure of, things that trigger autoimmune condition, it is definitely possible that it might manifest this early, but we have a hard time identifying it in these age groups. A little bit easier in kids who are in middle school and high school, but it does also emerge in preschool. And again, it's kind of based on how the evolution of daytime sleepiness appears. So younger preschool kids or grade school kids, may not necessarily be sleepy, but they may have learning difficulties, whereas adolescents may actually tell you that they are always sleepy or they're always tired. But if you do see napping that occurs and the teachers are reporting this, and this is despite getting enough sleep, you should be concerned about a disorder like narcolepsy. If you have like unexplained drops in school performance, always probe about a sleep disorder, in my opinion. Definitely if you're noticing mood disturbances or behavioral changes coupled with some of these symptoms, it's always good to ask about how the child is sleeping. Again, cataplexy can also emerge here, and then more often it will get misdiagnosed as epilepsy. And then the notion of automatic behaviors becomes a little bit more, how I'd say, like a little bit easier to pick up on when the child is involved in that description. So we do start to see some of that actually occurring in kids that are in school. Just a couple of quick words on IH. Obviously we've already talked about the differences in sleep study and MSLT testing, so I'm not going to go over that. But it's important to recognize that this is probably, for a lot of patients, these symptoms are probably starting during adolescence. It's the same notion that they are having daytime sleepiness, but some of the more cardinal features are this idea that they're having morning sleep drunkenness or unrefreshing naps. Just like narcolepsy, we really have a tough time establishing what the prevalence of IH is in kids. But we think, just like narcolepsy, that the symptoms probably started during adolescence. And then, of course, we already talked about how the MSLT, there's a great question, could you actually have both? And it could just be the quality of the MSLT. But lo and behold, one thing that also makes it a little bit tough to differentiate these things is that they're shared treatments, right? So once you get a condition like this, we use a pharmacological therapy that we may also use for narcolepsy. And we don't often think about repeating the MSLT later because they're already under treatment. So they might have this label from the very beginning. I always wonder, for some of these kids who I've diagnosed, we had this discussion last night over dinner, but we have a kid that, that I've diagnosed with IH simply based on not having sleep onset REM periods during their MSLT. No cataplexy, but that they were diagnosed with IH, didn't really have a lot of the clinical features of IH, but because of the positive MSLT, I put that child on stimulants, and the child's actually responding quite well. Do I feel hard-pressed for an academic reason to go ahead and say, hey, can you come back for another MSLT, or let's do a lumbar puncture? Because ultimately, we're trying to improve their quality of life. So there may be a lot of people who get diagnosed with both. And I'm actually kind of curious by looking at these insurance claims, whether that happens, and clearly when they're on these therapies, you really don't know if the therapy was specifically for IH or whether it was specifically for NH type 2. So I really like this slide. This is a slide from my friends in Cincinnati from Narong Simikajornbun, and sorry, it doesn't really, the print is very small, but I'll try to spend some time kind of going through this. In the medical world, let me see if is my mouse here? No, okay. The mouse was there? Oh, there we go. All right. So in the medical world, right, what we fixate on are outcomes. We want to see improvements, right? We want to see that the symptoms are controlled. Sometimes we'll use, I don't, but some people use an MWT to verify improvements in outcomes. But we want to make sure that performance at school, performance at work, driving safety is very relevant. But before we fixate on the outcomes, there is this, what I think, this orchestra of different things that are happening in children and even adults with central disorders of hypersomnolence. So clearly we talked about biological aspects to this, that there are different depths of how severe the condition can be. It may be related to how much functioning hypocretin there is. It may be related to how your GABA signaling is. So we have, obviously some of these tests are not easily accessible in terms of the clinical practice. Maybe from a research perspective we can answer those questions. But we know there is this idea that biologically we can explain a lot of these symptoms. But in addition to biological, there's just even aspects of how people sleep, right? So, we know these conditions affect their sleep, but we also know there are other aspects that can affect one's sleep. So, for example, sleep hygiene is a big concern for a lot of folks, including if you have a disorder of hypersomnolence. There's circadian aspects here that we have to be mindful of. Some people are night owls, right? But they have to start their job early. And so there is this idea that, you have this biological tendency to be hypersomnolent, but there's also aspects of one's sleep and sleep regulation that might come into play. And of course, in these conditions, as you all know, that especially when you have narcolepsy, you just can't have regular sleep. So it's sort of this interplay of environmental factors, of biological factors that can actually play. And so you can see that the arrow is really bidirectional. But in addition to those, there is a circle that's talking about social and contextual aspects of how one feels. And some of these symptoms of narcolepsy and IH may be entirely related to what the stress you have at home, or the stress you have with your relationships with your friends, or the stress that you have related to your job, or if you now have kids. So there are these factors that are also coming into play that do also affect those outcomes that we're so fixated on. And then finally, and very relevant in the adolescent population, is the psychological component of this. So if you are having daytime sleepiness, you are much more likely to have a slowing. Your thought process is impacted. It could actually cause mood disturbance. Thank you. So in this context, we really need to recognize that there is this orchestra of different things that are happening. And while we look at the outcomes, we really should be looking at all four of these circles when we approach anybody with these conditions. All right, I'm going to quickly talk a little bit about treatment. Pharmacotherapy is going to be covered a lot. I think one of the most exciting things about coming here is I just marvel about how much drug development has happened in central hypersomnolence. We are really on the cusp of seeing some amazing pharmacological therapies. Did it go too far? Yeah. But I think I want to talk a little bit about behavioral interventions and psychosocial and educational interventions. These are quite relevant in children. So when we think about sleepiness, one thing I think is really important is that first appointment you have with your clinician or provider, because you need to come up with realistic treatment expectations, and you also need to recognize that evolves. Like, things might work really well in the beginning, or they might work well later on, or there might be newer medications that might work. I was just speaking to somebody about how they've kind of gone in and out of different types of regimens for treating his narcolepsy, and I was like amazed how, just if you take an individualized approach, you can see that the reality is it's not one size fits all when we treat hypersomnolence. Oh, I don't know why my slides are advancing so fast. Okay, and then, so some things for kids that we think about is dosing. This is a big challenge because kids are growing, and so we have to look at, we usually tend to start low for the idea that we want to minimize side effects, but we recognize, I have no idea, this is on its, I guess, a schizophrenic computer. We have to recognize that things change as kids get older. And so we need to expect that we're going to have a lot of unfortunate trial and error that sort of emerges with a lot of these kids. We also need to think about side effects, that some of these are more specific to pediatrics, like, if we think about growth suppression related to some things like stimulants. I think we also need to think about cardiovascular effects. Then we need to think about compliance and tolerance. And these are all really, I think, very relevant aspects to to kids, because one thing that's critical about pediatrics is growth and development. And so when I see a child at the age of 6 or 7, and I see them 5 years later, they have very different concerns as a teenager as they did as a 6-year-old. For example, there may be girls who are on oral contraceptives, and some of these medications will interact. And so you have very different discussions, a lot really dependent on the actual age of the child. Behavioral strategies, you've heard this already. I'm not going to go too much about this, but I think one thing that I want to highlight here is the concerns for driving. Because a lot of, as you know, hypersomnolence disorders has a huge impact on driving. Well, teenagers with these disorders are also learning to drive. And so we have to couple that with the safety. And so I do have a lot of parents that just don't feel comfortable at all having their teenager drive, period, full stop. And so in that context, that's a really challenging discussion that I have, because I'm not a parent, I'm not parenting the child, and so you really need to kind of see the comfort level of both parties. Okay, I think just in the interest of time, just want to kind of go straight to well, let me just also show this one slide here. So quality of life, we know a lot about quality of life, and this is from the slide before, where they actually looked at adults with narcolepsy compared to other conditions like Parkinson's, migraine headaches, and epilepsy. And narcolepsy tends to really reduce quality of life measures in all the domains. Not a lot of data in kids, but I found this slide pretty interesting. This is just looking at narcolepsy, epilepsy, and those patients without. So the real comparison here is epilepsy. And even compared to epilepsy, kids with narcolepsy were much more likely to have mood disorders, conduct disorders, somatic disorders, oppositional defiant, and of course ADHD. So there is a real aspect about how quality of life, as well as other aspects to mental health, can emerge as young as children. So just to conclude, because I think my time's up, and I apologize with the slides, I just want to make sure that we recognize that with the reason for the 10-year delay in narcolepsy, and perhaps the same with IH, is that features are not typical. It's hard for us to recognize these conditions. And one of the goals that I really want to do is educate pediatricians, because that's generally where kids are going for these conditions. And a lot of pediatricians are not aware of what narcolepsy is, and they tend to think that this is a disease that only in adulthood. The other aspect I want to I want to reemphasize is that pediatric narcolepsy, there are so many moving fronts in children and teenagers that we have to recognize are clearly affected by disorders like narcolepsy and IH. Whether it's school performance, it can also include physical health, it can also include psychological functioning. And so when we see kids, I think it's really relevant to not only try to establish a diagnosis, but establish an ideal treatment algorithm for that population. It's really understanding the background of the child, the background of the family, and working together, because we want to try to, if you think about that slide that showed the different circles, what I call a different musical, the woodwinds and the brass instruments, we all come together to try to come up with a singular improvement, and it really takes a multidimensional approach.